Now coming to idiopathic intracranial hypertension. So in the name itself, you can see this is idiopathic, like unknown reason, and that is leading to intracranial hypertension inside the brain. And this is also called as pseudotumor cerebri. Here, the intracranial pressure is raised because of some risk factors. The mnemonic is TOAD. It's female TOAD because mostly female is involved, and T here represents tetracycline, O for obesity, A for vitamin A excess, and D for denazole. So this is associated with dural venous sinus stenosis. Here the findings are headache, tinnitus, diplopia, and no change in mental status. Here get impaired optic nerve axoplasmic flow. Because of that, you may get papilledema. And the visual field testing shows enlarged blind spot and peripheral constriction. So the treatment here is weight loss, acetazolamide, and also we can do CSF shunt placement. Now coming to hydrocephalus. What is hydrocephalus? Hydrocephalus is increased CSF volume, so that is leading to ventricle dilation and that will raise intracranial pressure. Here you have communicating type, non-communicating type, and ex vacuo ventriculomegaly. So first one is communicating type. Communicating hydrocephalus is where you get low CSF absorption in arachnoid granulations. So this is the reason why you get more intracranial pressure, because arachnoid granulations are not able to absorb the CSF. So here the key sign is papilledema and herniation. Next, coming to normal pressure hydrocephalus, it affects mostly adults, and here the CSF pressure is elevated episodically. That will lead to increased subarachnoid space, and this will lead to expansion of ventricles. So here this triad of urinary incontinence, gait apraxia, cognitive dysfunction. So you can remember it as wet, wobbly, and wacky. Treatment is ventriculoperitoneal shunt, which can drain CSF to abdomen. Now coming to non-communicating hydrocephalus, this is because of structural blockage of CSF within ventricular system, because of block of aqueduct of Selvas or blockage of Monroe or any tumor. Now coming to hydrocephalus mimic, that is ex vacuo ventriculomegaly. Here the problem is the brain tissue and the size has become less, like it has undergone atrophy. So because of that, the CSF appears to be more. It just appears to be more, but it's not more. Example: Alzheimer's, advanced HIV, frontotemporal dementia, Huntington disease. And here the ICP is normal, but it appears to be more because of decreased brain tissue. Now coming to multiple sclerosis. So multiple sclerosis is an autoimmune inflammation, and there's demyelination of both brain and spinal cord, and also there's axonal damage. So the features are optic neuritis, brainstem and cerebellum syndrome. You get pyramidal tract demyelination. Spinal cord syndrome is like you get electric shock like feeling whenever we bend or flex our neck. And you get neurogenic bladder. Sensory manifestations affect trunk or one or more extremity. Symptoms may exaggerate with increased body temperature, like if they go for bath or exercise, their symptoms may increase, and their relapse and remitting is most common clinical course. Mostly you can see multiple sclerosis in females in their 20s and 30s, and this is most common in individuals who grew up farther from equator, like near to cooler regions. So they may also have vitamin D deficiency. So coming to the findings here, the IgG level is very high and the myelin basing protein in the CSF is high. The main diagnostic point is oligoclonal bands, and MRI is the gold standard. You can see here the periventricular plaques, which is also one of the clue for multiple sclerosis, where there's areas of oligodendrocyte loss and reactive gliosis. Multiple white matter lesions are disseminated in space and time. So the treatment is just to stop relapse and halt or slow progression with some therapies like beta interferon, natalizumab, and you can treat acute flares with IV steroids. Symptomatic treatment for neurogenic bladder is catheterization or muscarinic antagonist or botulinum toxin injection. For spasticity, we can give baclofen, GABA agonist, and for pain, we can use TCA anticonvulsions. This diagram can explain multiple sclerosis. It can affect eyes like optic neuritis, diplopia, nystagmus, INF. And neurologically, you can get fatigue, depression, ataxia, intention tremor. In speech, you can get dysarthria, scanning speech. In spinal cord, you can get sensory symptoms, weakness, spasticity. In urinary, you can get urinary incontinence. So, this is about multiple sclerosis. Now coming to other demyelinating and dysmyelinating disorders. Here the first one is osmotic demyelinating syndrome. This is also called as central pontine myelinosis. There is massive axonal demyelination, especially in the pons white matter. This is secondary to rapid osmotic change, most commonly iatrogenic correction. Like if we give someone has come with hyponatremia, and if you suddenly give more like sodium to them, then you can get this problem like acute paralysis, dysarthria, dysphagia, diplopia, loss of consciousness. This is also called locked in syndrome. So never correct sodium too fast. If you correct it from low to high, your pons will die because you'll get osmotic demyelination syndrome. If you correct from high to low, your brains will blow, like you get cerebral edema or herniation. Now coming to acute inflammatory demyelinating polyneuropathy, like it's a most common form of Guillain-Barré syndrome, which is an autoimmune condition. It's a peripheral nervous system disease. So your squam cells get destroyed by either inflammation or demyelination. So because of this, you may get many infections. Like it is associated with infections like Campylobacter jejuni virus, Zika virus, and it results in symmetric ascending muscle weakness or paralysis, or it can get depressed or absent DTRs, which begin especially in lower extremities. You can also get facial paralysis, respiratory failure, these are common. Also get autonomic dysregulation like cardiac irregularities, hypertension, or some sensory abnormalities. Most patients survive with good functional recovery. You can get high CSF protein with normal cell count, and respiratory support is critical because here the respiratory system is getting affected, and the treatment also can give plasma exchange or IV immunoglobulins. Now, coming to acute disseminated encephalomyelitis, this is multifocal inflammation where there's demyelination mainly after infection or vaccination. So, this can rapidly progress into many neurological symptoms and also altered mental status. Now coming to Charcot-Marie-Tooth disease, in the name itself you can see CMT, like can't move toes, because there's pes cavus, hammer toe, and lower extremity weakness like foot drop, and also associated with CMT1A mutation, which is caused by PMP22 gene duplication. Now coming to progressive multifocal leukoencephalopathy, this is demyelination of central nervous system, mainly destruction of oligodendrocytes, which is associated with JC virus, and there's also association with immunosuppression like either lymphoma or leukemia, AIDS, or organ transplantation. This is usually fatal, and it's predominantly involves parietal and occipital lobes. So, as it's involving occipital lobe, visual symptoms are also common, and there's increased risk associated with natalizumab. So, there are also some other demyelinating and dysmyelinating disorders like Crab disease, metachromatic leukodystrophy, and adrenal leukodystrophy. Now let us discuss about neurocutaneous disorders. The first one is Sturge-Weber syndrome. This is non-hereditary anomaly of mainly neural crest. Here there's somatic mosaicism involving mutation of GNAQ gene. Here there's capillary vascular malformation, so it will cause port vein stain, and the cranial nerve 5 is mostly involved. That will lead to ipsilateral leptomeningeal angioma. And there's scissors, epilepsy, intellectual disability, episcleral hemangioma, that will lead to increase in rise of intraocular pressure, and that will lead to early onset glaucoma. So this is also called encephalotrigeminal angiomatosis. Now coming to tuberous sclerosis, this is autosomal dominant disease. Here there's a problem with TSC1 on chromosome 9, TSC2 on chromosome 16. So there are many hematomas in CNS and skin, and there are angiofibromas, and there's also mitral regurgitation, Ashleigh spots, and cardiac rhabdomyoma, intellectual disability, renal angiomyolipoma, Sjagren's patches, and there is also increased incidence of subependymal giant cell astrocytomas and ungual fibromas. Now coming to neurofibromatosis 1, it's 100% because of NF1 gene mutation on chromosome 17. There are capillate spots, intellectual disability, cutaneous neurofibromas, Lish nodules, optic gliomas, pheochromocytoma, scissors, signs. So you can remember the mnemonic Cyclops, 17 letters. And this is also called as von Recklinghausen disease. Now coming to neurofibromatosis 2. This is on chromosome 22. There's bilateral vestibular schwannoma, juvenile cataracts, meningioma, ependymoma. Now coming to von Hippel-Lindau, it's autosomal dominant. There's defect in VHL gene, and the mnemonic is HARP, hemangioblastoma, angiomatosis, bilateral renal cell carcinoma, and pheochromocytoma. And it is VHL is of 3 letters, so it is involving chromosome 3. This is also associated with renal cell carcinoma. Now coming to adult primary brain tumors, the first one is glioblastoma. So this is grade 4 astrocytoma, most common highly malignant brain tumor. If someone gets this, maybe only 1 year they can survive, and this is found in cerebral hemispheres. It's actually also called butterfly glioma, and it is associated with EGFR amplification. Of course, it's of astrocytogen, so it's GFAP positive, and it has pseudo palisading pleomorphic tumor cells, and the border is made up of this, and the center there's necrosis, hemorrhage, and also proliferation. Now coming to oligodendroglioma, it's a rare slow growing tumor. It is found in frontal lobes, and this is often calcified. It's having fried egg appearance and chicken wire capillary pattern. Now coming to meningioma, this is most common benign tumor in females, and the main thing is it contains some bodies by which we can find it out, and it's also extraaxial and also may have dural attachment tail-like structure. So the treatment is just to resect the tumor. Now coming to hemangioblastoma, it's the most common cerebellar tumor associated with von Hippel-Lindau syndrome, and it is also associated with retinal angiomas. It is of blood vessel origin, and it is closely arranged thin walled capillaries with intervening parenchyma. Next, pituitary adenoma. This is either non-functioning, silent, or hyper-functioning. It may cause bitemporal hemianopia, and it will mainly put pressure on optic chiasm, pituitary apoplexy, and finally hypopituitarism. In prolactinoma, there is galactorrhea, amenorrhea, and decreased bone density due to suppression of estrogen in females, and there's also low libido, and this will lead to infertility in males. Treatment is dopamine agonist, cabergoline, all those things. Here's this hyperplasia of one type of endocrine cell. So most commonly it is from lactotropes and less commonly from somatotropes. It may lead to acromegaly, gigantism, Cushing disease, all those. Schwannoma is classically at cerebellopontine angle. It is benign. It involves cranial nerve 5, 7, 8, and often localized to mainly cranial nerve 8, and in internal acoustic meatus to vestibular schwannoma. It's bilateral vesicular schwannoma found in NF2. So treatment is again resection. As it is of Schwann cell origin, the marker is S100. So these are the different diagrams. You can see this one is glioblastoma, butterfly shaped, and next this B represents even the same glioblastoma, and C represents oligodendroglioma, D represents oligodendroglioma fried egg pattern, E represents meningioma, F for meningioma, same, some bodies, you can see the whole pattern. G is for hemangioblastoma, H also hemangioblastoma, and I is for pituitary adenoma. In normal patient, you can see in bitemporal hemianopia, you can see how the patient's vision is. Next, J also represents pituitary adenoma, K is for schwannoma, L is for schwannoma. Schwannoma, these are myxoid areas, spindle cells, you can see. This is schwannoma. Continue with childhood primary brain tumors. The first one is pilocytic astrocytoma. Actually, in the name itself can see astrocytoma. So it's of astrocyte origin, so it will be GFAP positive. Okay, and this tumor is low grade. Actually, it's most common primary brain tumor in childhood, because now we are discussing about childhood tumors. It is most common in childhood, and in children it is usually present in posterior fossa. Okay, this diagram you can see. In the posterior fossa, you get this astrocytoma, especially in children, where the cerebellum may get affected, and it is supratentorial. In children, it's supratentorial. In adults, it's below the tentorium. That thing you need to remember. And this is a benign tumor, so it has good prognosis. Okay, and this is positive for bipolar neoplastic cells, which are hair-like projections, which are associated with microcyst and rosenthal fibers and also corkscrew fibers. You can see this diagram. This shows corkscrew fibers. Next, coming to medulloblastoma, this is most common malignant brain tumor in childhood. So pilocytic astrocytoma is benign, whereas medulloblastoma is malignant brain tumor in childhood, and it involves cerebellum. Okay, you can see this one is medulloblastoma, which can compress the fourth ventricle and causing non-communicating hydrocephalus. So this will lead to headache, papilledema, and sometimes it can also involve the vermis of cerebellum. And if vermis get affected, then you may get truncal ataxia, and it can also send drop metastasis sometime to spinal cord, because it has come till medulla, right? So it's very nearer to spinal cord. So this is having a p-net marker, and you can also see hormone right rosettes surrounding the neutrophils. This diagram shows the homophylaris surrounding the neutrophils, and this is synaptophysin positive tumor. Next, coming to ependymoma, we know ependymal cells actually line the ventricle. So if this get affected, you will get especially in fourth ventricle tumor, and this can also cause hydrocephalus. So this has rod shape belaroplast. So this one is ependymoma. This is also common in children. Now coming to craniopharyngioma. Craniopharyngioma, this both diagrams represent craniopharyngioma. This most common childhood supratentorial tumor. Okay, pilocytic astrocytoma is also supratentorial. Even craniopharyngioma is supratentorial. But don't confuse this with pituitary adenoma, because both of them were caused by temporal hemianopia. But pituitary adenoma is seen mostly in adults, whereas craniopharyngioma is seen in children. Okay, and this is derived mainly from the remnants of Rathke's pouch, and the calcification is common. Cholesterol crystals are also seen, and the motor oil-like fluid is present within the tumor. Now coming to pineal gland tumors, this is most common extragonadal germ cell tumor. It's more common in males and presents with obstructive hydrocephalus because of compressing the cerebral aqueduct. And even the peritonic syndrome, where this compression of dorsal midbrain is associated with this. There's a triad of upward gaze palsy, convergent retraction nystagmus, and light near dissociation. This pineal gland tumor is similar to testicular seminoma. Now coming to herniation syndrome. So first herniation is cingulate, also called, this is false reply, so falcine herniation. This can compress anterior cerebral artery, and if anterior cerebral artery gets compressed, then contralateral legs may get affected. Now coming to central or downward transtentorial herniation. Because of this, there's rupture of basilar artery branches, and you may get urate hemorrhages, and it is fatal. Now coming to third one, uncal herniation, and here its uncus is actually medial temporal lobe. So if it gets herniated, you get ipsilateral blown pupil, contralateral hemiparesis, and in late stages you may get coma, and also you may get Kernohan phenomena. Now coming to fourth one, this is cerebellar tonsil herniation, which is going into the foramen magnum. If this happens, you may get coma and also death. Because of this herniation, you will compress the brainstem, so you get coma and death. Now coming to motor neuron signs, it's very simple. If you understand upper motor neuron and lower motor neuron is always upper, like you get spasticity, you get everything high there, whereas in lower motor neuron everything will be low. So you can see lower motor neuron everything is low, like less muscle mass, less muscle tone, less reflexes, downgoing tones. That means Babinski sign is negative. Whereas if you say upper motor neuron, here everything is up, so you get more tone, more DTR. Your toes will go up, like Babinski sign will be positive in upper motor neuron. Fasciculation is muscle twitching. Fasciculations are more common in lower motor neuron. And one thing you need to know, that weakness is present in both upper motor neuron and lower motor neuron lesions. So that's why weakness both. Atrophy, you can say now it is low, so lower motor neuron. Fasciculations is low, so lower motor neuron. Reflexes, will be high in upper motor neuron, low in lower motor neuron. Tone will be high in upper motor neuron, low in lower motor neuron. Babinski sign positive in upper motor neuron, negative in lower motor neuron. Spastic paralysis will be positive in upper motor neuron, negative in lower motor neuron. And flaccid paralysis is negative in upper motor neuron, positive in lower motor neuron. Clasp knife spasticity is positive in upper motor neuron and negative in lower motor neuron. Now let us discuss about spinal cord lesions. So here there's spinal muscular atrophy, that is degeneration of anterior horns. In this diagram you can clearly see. So as the anterior horns are gone, the lower motor neurons will be affected, and if the lower motor neuron is affected, you'll get flaccid paralysis, you'll get fasciculations, and there's especially mutation of SMN gene. So because of spinal muscular atrophy, so SMN gene, that gene is getting affected. So this disease is also called Wernig-Hoffmann disease. So this is a disease where there's a mutation in the SMN gene. So because of that, the anterior horns are gone in the spinal cord, so the lower motor neuron is getting affected. So if lower motor neuron is getting affected, you'll get fasciculations, flaccidity, etc. Now coming to amyotrophic lateral sclerosis. Actually here the problem in the name itself, you can see amyotrophic lateral, but I remember like anterior lateral sclerosis because it affects both the anterior horn and the lateral horn. So if anterior horn is affected, lower motor neuron is affected. If lateral horn is affected, upper motor neuron is affected. So both lateral and uh, anterior horns are affected, means both lower motor neuron and upper neuron are affected. So you get both symptoms, like you may get fasciculations, at the same time spasticity. You may get positive Babinski sign and also negative Babinski sign. So both are affected, and this disease is called Lou Gehrig disease. So the treatment is also riluzole. Okay, so very simple. Now coming to complete occlusion of anterior spinal artery. So if the anterior spinal artery is occluded, especially it supplies to upper motor neuron lesion, which is below the lesion because of corticospinal tract, and lower motor lesion at the level. So because of this, you may get loss of pain and temperature sensation below the lesion in spinothalamic tract. So this is about anterior spinal artery. Now coming to tabes dorsalis, this is because of tertiary syphilis. This degeneration or demyelination of especially dorsal column. If the dorsal column is gone, you may get ataxia, you may lose proprioception, and even the Romberg sign will be positive, and this is associated with Charcot joint, shooting pain, and Argyll Robertson people. All these are related with syphilis. Now coming to syringomyelia. Syringomyelia, it's a problem where your white fibers are gone. So only in upper extremities you may lose the pain and temperature capacity. But if this syringomyelia may also go to the lateral horn, you may get Horner syndrome, ptosis, meiosis, and anhidrosis. Okay, and this syringomyelia is also associated with Chiari-1 malformation. Now coming to cauda equina. Cauda equina syndrome is compression of spinal root L2 and below. So because of herniation or tumor, you get this, and you'll get the radicular pain and absent knee and ankle reflex, also loss of bladder and sphincter control. So you saddle anesthesia here. So compress cauda equina. Now coming to poliomyelitis. So polio is a virus which somehow enters your body. After entering, it will go and affect especially the anterior horn of the spinal cord. So as your anterior horn is getting affected, your lower motor neuron will be affected. As your lower motor neuron is affected, mainly your legs get affected. Lower motor neuron means you get fasciculations. So mostly you get fasciculations, asymmetric weakness or sometimes symmetric weakness. You get all lower motor neuron symptoms like hypotonia, flaccid paralysis, fasciculations, hyporeflexia, muscle atrophy, respiratory failure. So all these are signs. So mainly the signs of infection are malaise, headache, fever. And if you take the CSF sample, you see more WBCs and you see increased protein. So virus is recovered. How to find out the virus? You can take it from the stool or either from the throat. Okay, so this is actually a single-stranded RNA virus. So polio is a single-stranded RNA virus. Now coming to Brown-Sequard syndrome. Here the problem is, you can see the brown side or the right side which is getting affected. So this half part of the spinal cord got affected. So the same side where the first spinal cord got affected, that side you will lose all the sensation, and also you will lose the lower motor neuron. So you get flaccid paralysis, and you lose the upper motor neuron on the same side. But the ipsilateral loss, yeah, even you lose proprioception, vibration on the same side which got affected, but you will lose pain and temperature on the contralateral side. So half side of the body is fully affected, but the other half of the body is fine, and in that half of the body only you lose the pain and temperature. So that is what you see in Brown-Sequard syndrome. Now coming to Friedreich ataxia, it's actually a trinucleotide repeat disorder where you get ga 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 repeating on chromosome 9. So it is because of frataxin gene which is leading to impairment in mitochondria. So here the problem is degeneration of lateral part of corticospinal trauma. So if the lateral part is gone, you can understand upper motor neuron is gone. So you get spasticity, all those kind of problem, and also get ataxia, because in the name itself you can see Friedreich's ataxia. Even the spinocerebellar tract is affected, so you get ataxia. And if the dorsal column is also involved, you will lose a vibration, proprioception, and you get staggering gait, falling, diabetes, hypertrophy, cardiomyopathy. Okay, so Friedrich is fretastic. He's your favorite frat brother, always staggering, falling, but has a sweet big heart, because cardiomyopathy, hypertrophic cardiomyopathy, right? And ataxic gait. So gait, GAA, Friedrich ataxia. Here you can see the diagram where they're representing hypertrophic myocardiomyopathy, diabetes mellitus, kyphoscoliosis, and high arches pes cavus. Now coming to common cranial nerve lesions. So if you lose cranial nerve 5, the jaw will deviate towards the same side where you got the lesion. If you get cranial nerve 10 lesion, then the uvula deviates away from the side of the lesion, like opposite side. And if you get cranial nerve 11 lesion, then you turn the head to contralateral side of the lesion, like opposite side. Or you may also droop the shoulder on the side of the lesion. And if you lost cranial nerve 12, then you get lower motor neuron lesion, like your tongue deviates towards the side of the lesion. Okay. Now coming to facial nerve lesion, it's a Bell's palsy, which is most common cause of peripheral facial palsy. It develops actually after herpes simplex virus activation. The treatment is glucocorticoids or acyclovir. And these patients gradually recover, but there's aberrant regeneration. So other causes of peripheral facial palsy are like Lyme disease, herpes zoster, sarcoidosis, tumors, diabetes. Now let us describe upper motor neuron lesion versus lower motor neuron lesion. If you get upper motor neuron lesion, you know your motor cortex, your connection from motor cortex to the facial nucleus in the pons, all this tract is getting affected, and the affected side will be contralateral side. For example, if your right side got affected, then that means the left side of the nerve got affected. So muscles involved will be lower muscles of facial expression, and forehead is paid because it is having bilateral upper motor neuron supply. So if only one side gone, the other side will supply, so this part will not affect. But the lower side of face is supplied only by one side of upper motor neuron, so this will get affected. Though now coming to lower motor neuron lesion, here the facial nucleus will be traveling along cranial nerve 7. Here the ipsilateral side only will get affected. In upper motor neuron, contralateral side will affect. In lower motor neuron lesion, the ipsilateral same side will get affected. Both upper and motor lower muscles of facial expressions will be affected. Both upper and lower side here is affected, but here only the lower side is affected. This incomplete eye closure, and this hyperacusis and loss of taste to the anterior tongue. So very important, upper motor neuron contralateral side muscle is affected. In lower motor neuron, ipsilateral side is affected. And in upper motor neuron, the upside is paid, only the lower part of face is affected. But in lower motor neuron, both upper and lower side have got affected.